Good morning, delegates. Warm welcome to this inspection symposium on macular surgeries. Myself, Dr. Rajaram Reddy from Neuretina, Hyderabad, and this is Dr. Martin Brillen from Hong Kong. We'll be chairing these sessions. The first topic for today's symposium is epiretinal membrane surgery, different situations by Dr. Tinku Bali.
Good morning, everyone. It's such a pleasure to be here this morning in front of you all. And I'll be speaking on the surgery for epiretinal membranes and showing you different situations for the same. So an epiretinal membrane is typically idiopathic, and the most important risk factor is age. It can also be secondary to retinal vascular diseases, uveitis, trauma, retinal detachment, or laser. Now, before taking up a patient, the patient's visual acuity and metamorphopsia are the two important factors that we consider. And the OCT picture does guide us in planning the surgery and also in prognosticating, wherein we look at the outer retinal layers, most importantly the ellipsoid zone. The OCT can also help you in your surgical planning, whether to see the configuration of the membrane, whether it's globally adherent, loosely adherent, and also tell you about the planes of separation. Now, before taking up any patient for surgery, a very good pre-op counseling is extremely important. You have to tell the patient that the vision and the metamorphopsia is not going to improve immediately after surgery. Most patients can expect a 2-line improvement, but generally it does come in after 6 months, and generally the vision sometimes goes on improving even up to an year. Poor preoperative vision and long duration of symptoms have worse visual outcomes. The surgery is standard. You do a pars plana vitrectomy, induce a PVD, stain with dyes, and then do an epiretinal membrane peeling or an ILM peeling if required. The two dyes that have really helped in this surgery are the trypan blue and brilliant blue. Trypan blue selectively stains the epiretinal membranes. It is of a higher concentration than that used by cataract surgeons. And brilliant blue dye selectively stains the ILM, and we can make use of these differential properties while we are doing the surgery. So I'll show you some situations. What I talked about was for idiopathic membranes, but I'll be showing you some secondary membranes. So this idiopathic membranes are generally avascular, but this is a vascularized epiretinal membrane following a branch retinal vein occlusion. This florid vascularization, the laser was done and the vascularization went down a bit, followed by an anti-VEGF injections, and you see the thick membrane there pulling up the retina. So some epiretinal membranes can come off while you've induced PVD itself. They can come off with the hyaloid phase, as in this one. It did seem like a very adherent membrane, but it simply came off while I did the PVD induction. And this is the post-op patient. There is some residual subretinal fluid, so this fluid need not be drained. It does absorb over a period of time. This was an unusual membrane. It's more like a thickening of the hyaloid face here. A very thick membrane present right at the center. And again, this membrane came off very easily while inducing the PVD. You see how thick this is? And this is the post-op result. So so you have to watch out whether your membrane has come off with the PVD induction or not. Now the surgery for epiretinal membrane is pretty simple and standard. The technique most often followed is a pinch and peel technique. You do not have to use any picks or MVR blade to find the edge. Now that we have dyes, the edge is very easily found. And you can simply go to the edge of the membrane. If you cannot find the edge, you can simply peel the ILM at the edge of that membrane, and then the membrane comes off easily. You move in a tangential manner. Now, some other caveats during surgery are, so here again, the pinch and peel technique. It may take a few tries. So you do it in an area away from the foveal center. And this is how you roll back the membrane on itself. You do not pull in the anterior-posterior direction. You go circumferentially, just like a capsulorhexis, so that you do not damage the foveal tissue. And if you feel that the peeling is not possible from one direction, you can always come from the other direction. So this is how it's done. Do not pull in the anterior-posterior direction. You can always restain the membrane and see. So that's a very good idea to restain. This is a diabetic membrane here. So you see the edge is very easily identified. There is some retinal whitening as these very tightly adherent membranes in diabetics, and sometimes that can be mistaken for an epiretinal membrane. You can always stain again to identify the edge. This is an epiretinal membrane in a vascular occlusion. So an extensive membrane on the macula extending even beyond the arcades. The edge is visible here even without the stain, but the stain really identifies it very well. So you simply take this and again move in a tangential manner. In these vascular membranes, it's very important to keep an eye on the other side of the membrane. So you see here one edge is attached to the disc. So you have to be very gentle in your peeling so that you do not pull and induce profuse bleeding at the disc. Now you see that talking about ILM peeling, cases like this which have a lot of internal limiting a lot of folds on the retina here. So these are the cases that you should do an ILM peeling along with the ERM peeling. Also, idiopathic membranes generally would not require a concurrent ILM peeling, but secondary membranes like post-uveitic, post-vascular occlusion, it's a good idea to do ILM peeling along with the ERM peeling. So you can use just one of the dyes, and this is something called the negative staining of the epiretinal membrane here, where the dye has only stained, the video is not working. Okay, the dye has only stained the internal limiting membrane and not the epiretinal membrane, and the negative staining can help you in peeling off the membrane. Sometimes, like I mentioned before, it may be difficult to find the correct plane. It may be difficult to identify the epiretinal membrane, as in this case, the macular hole case. This is the epiretinal membrane, but I'm not sure how this is going to be attached to the fovea, whether I'm going to damage the fovea or not when I'm pulling this membrane. So the ILM away from this membrane is peeled, and as you peel the internal limiting membrane, the epiretinal membrane comes off along with it. So this is a very good technique in cases of very adherent membranes. You can just peel the ILM away from the epiretinal membrane and the membrane comes off along with it. Post-uveitic membranes, as you can see in this video, are sometimes very tightly adherent. They are more elastic, and you do have to apply quite a bit of force to peel off these membranes. They are very rubbery and elastic in texture. These membranes, again, tend to recur more often. So again, like I said, an ILM peeling would be good. Again, you see the direction. You have to fold the membrane on itself and not pull in an upward direction so that you do not cause any pull on the retina. For membranes like this is a combined retinal detachment. You can find the proper plane of cleavage, the proper tissue separation plane at the disc. So you can pull this membrane with a forceps at the disc itself. Since the retina is very thick in the peripapillary area, there are very few chances of inducing a break. So once you've got this membrane off at the disc, you can use a cutter to then remove this membrane. For diabetic membranes, generally the cutter works very well. Now that we have the 27 gauge cutter, it can go under these membranes, you can segment, you can delaminate, you can segment, and you can go really close to the retina, you can go very close to these vascular pegs and cut off the membrane very safely. So the cutter itself does the job very well. Again, you can use an inside out or an outside in technique depending on the case. So you have to tailor your technique to the case. In this case, I was apprehensive that if I started at the disc and made a tissue separation with the forceps at the disc, I would have profuse bleeding. So that is why I'm using this coming from away from the disc and coming towards the disc so that I do not pull at the disc tissue at the disc and cause bleeding. Here you see this vascular peg. This tissue is attached to this vessel here. So very gently you have to separate it off. Also the membrane has extensions at the posterior pole. You can gently tug at it and see the attachments. And here you see with the cutter itself, you can get the entire membrane off. So you should keep your suction a bit low at this time so that you do not inadvertently get the retina into your port. So that's the end of the surgery. So again, showing you segmentation in another diabetic patient, similar. Now, in retinal detachments with PVR, it's very important to find...
Doctor,
Yeah.
We
Okay.
take a questions on
Okay,
this
fine.
page.
Yeah,
Yeah,
thank
one
you.
question. Excellent videos. I would say, what's your take on this classification of epiretinal membranes and based your surgery on AIFL and probably operating at an earlier stage of stage 2 when the AIFL is just formed rather than letting it go and to form a macular pucker and disorganization of the retinal layers?
Yes, I know. There's been a lot of papers coming out on this AIFL. I personally have not looked at these biomarkers in my practice since these studies have recently come in. But yes, if you do follow up, there would be a subset of patients who would stay very stable over the years, and there would be a subset of patients who would show progression on the OCT. So it's not just the OCT, you keep the patient's vision and the symptoms in mind and then decide to take the patient up.
Dr. Martin, I think it would be better to operate at the stage 2 when the AIFL is just formed rather than wait for it to progress.
Absolutely, and actually that was going to be my question is, all the case examples that you've demonstrated here are beautifully operated on, but they're all quite advanced membranes. And I think the big controversy about ERM surgery is on the other end of the spectrum is what do we do with the milder ones? At what stage should we offer surgery and in what sort of timely manner should we be doing those surgeries? So what's your take on kind of a different type of patients, for example, where vision is still pretty good, 20/25-69, they got mild metamorphopsia and the OCT has a mild ERM. What do you do in these sort of cases?
So I would leave it to the patient's decision. If the metamorphopsia is really bothering him, then I would definitely ask him to go in for surgery, provided he's willing. Also would look at other factors, his lifestyle, his visual needs. With a patient with 6/9 vision and mild metamorphopsia, I would not push the patient. I would ask him whether he requires the surgery or not.
Yeah, I mean, personally, I look for evidence of progression. So I would see if the patient's vision is deteriorating, if it's symptomatically getting worse, or if the OCT is progressing. Those cases I would maybe do a bit earlier. Any comments from the floor on that topic? Okay, then maybe we'll move on.
Thank you, Dr. Tinku, for excellent talk. Now we invite Dr. Chung Mei Yang for his talk on inverted epiretinal proliferation membrane flap indications and results.
Thank you, Chair, my dear colleagues. First, I'd like to thank the organizing committee for the kind invitation. Today, I'm going to talk about inverted epiretinal proliferation, EP tissue flap for repair of macular hole and lamina macular hole. In this presentation, I'll first briefly discuss the characteristics and significance of EP, followed by indication and surgical results of inverted EP tissue flap. The characteristic feature of EPR is yellow in color, thick, with medium reflectivity. It connects with the middle retina. It grows above ILM, ERM, or on both sides of posterior hyaloid. It is mainly located at hole edge, but may also be widespread. The significance of this biomarker can be reflected in the following aspects. First, it signified tangential traction-induced macular hole, as the three examples show. Second, EP is also almost always associated with ERM or broadly attached posterior hyaloid. Third, macular hole with EP has a higher rate of spontaneous closure or closure reopening cycles, as the two examples shows. This unique features justifies surgical timing modification. 3 to 4 weeks or more may be allowed for spontaneous closure. Once macular hole size enlargement is detected, surgery can be arranged soon. Next, when EP is present, the surgical approach may be modified. Instead of IM peeling or inverted IM flap, EP embedding or insertion may be an easier and an equally effective way to treat macular hole or lamina macular hole. Now, we move on to discuss another treatment way, inverted EP tissue flap. In this study, 2 additional significant features of EP were found, which I'll discuss later. We examined cases of lamina macular hole or full-thickness macular hole treated with EP flap. The surgical indication technique and results will be reported, as well as the advantage and limitation of the procedures. The surgical indication, in short, were those eyes suitable for EP embedding and with extensive EP. The disease categories included lamina macular hole, full thickness macular hole with or without high myopia, persistent macular hole, and myopic traction maculopathy with lamina macular hole or full thickness macular hole. We use two techniques for EP flap. Either the EP flap is created 360 degrees and visco injected around the base of the flap to push, guide, invert the flap to cover the hole. Or the EP flap is created in one quadrant or more and then inverted to cover the hole. The second technique is useful in those cases of myopic traction maculopathy with lamina macular hole, macular schisis, and extensive macular atrophy. In such cases, IRM peeling is difficult and the central foveal location is indistinct. It should be noted that the EP flap may also contain IRM and or conventional ERM tissue. Post-operative best-corrected visual acuity significantly improved in both lamina macular hole and full-thickness macular hole groups. Post-op OCT showed all cases achieved desirable anatomical improvement. Tissue of median reflectivity within the hole and thick membrane on top of the fovea with or without ERM fragments were noted. There was no evidence of glial proliferation despite frequent presence of conventional ERM mixed with the EP tissue. 2 macular hole cases developed lamina macular hole after surgery. As shown in this slide, lamina macular hole with mild schisis developed after successful macular hole surgery, indicating loose EP retinal adhesion and or incomplete traction release. This loose EP retina adhesion was another feature of significance of EP. The advantage of the technique is that it is less traumatic to the macular hole or lamina macular hole floor when compared with EP embedding. Once the EP tissue is identified, it is less technical demanding than pure IRM flap, especially in high myopia, because the EP tissue is thicker and more tear resistant. The major limitations are first, EP tissue identification before peeling may be difficult because EP does not take dye staining. Second, a large piece of EP tissue is required for this technique. In this technique, it's difficult to have a pure EP tissue as a flap because EP is likely to mix with ERM and IRM, and the flap usually contains EP along with some ERM and IRM. After EP flap created, it may not be necessary to peel IRM in lamina macular hole cases, but in full thickness macular hole cases, it may be better to further peel IRM to release more traction. Let's see some examples. This was a case of lamina macular hole with extensive EP and a degenerative configuration. EP flap for 360 degree was created, trimmed, and covered the lamina macular hole under visco assistance. Visco was injected around the base of the flap to push, guide, and invert the flap to cover the hole. IRM was not peeled. After surgery, EP blended together and filled the central defect was noted. Let's see the video. We can see the posterior hyalo is attached. So we peeled it with cutter, suction. After that, we stain the tissue with ICG. Then we can see the central area is not stained. Only the peripheral is stained. Then we peel from the IM stained area, and then we encounter this yellowish, thick epiretinal proliferation tissue. It's very extensive and around the hole for 360. All the non-stained area contains this EP. It's yellow in color, so it's easy to identify. And because it's thicker, it's not easy to get teared. So after we perform the EP separation for 360 degree, we use the cutter, use the shaving mode to trim it to a small, to make it smaller. And then we use we stain again to prove that IM is still there. No peeling area is still not stained. So we use a visco to push on the base of the flap, to push it and guide it toward the center for 360. After that, we just leave it there without touching the floor of the macula, lamina macula. And after that, air fluid exchange. So that's basically, that's it. And this case, with macular hole, extensive EP under 2 cycles of closure and reopening. After surgery, macular hole was closed. I see the video is the same, except that the EP is not that extensive. We still peel find the EP tissue, peeling from the IM. In this case, the extra step is that we use the cutter to cut the IgG stain the IOM. So the traction is more completely released, and there's no possibility, decrease the risk of dye toxicity on the macular floor. And it's the same. We use the visco guided to. So this another high myopic patient had a large macular hole. After surgery, the macular hole was sealed. In addition to EP tissue, we can see the IM tissue could be seen in the center, pointed by red arrow. In another high myopic patient with myopic traction maculopathy and central or paracentral patchy macular atrophy, a wide lamina macular hole with macular schisis and a thin floor was noted. EP flap was created in one quadrant and covered the central defect. We used the second technique. And this 60-year-old high myopic patient had previous surgery for myopic traction maculopathy. Unfortunately, macular schisis and foveal detachment developed after surgery. We performed EP tissue peeling and inverted EP flap. The macular contour recovered soon after surgery. This surgical result demonstrates another significant point of EP. That is, although EP is non-contractile, it remains an important traction component. EP peeling should be part of the procedure to treat myopic traction maculopathy. In summary, inverted EP flap may be a good option for select patients with lamina macular hole or full thickness macular hole. I'd like to thank my colleagues who helped me with this talk. Thank you for listening.
Thank you, Dr. Yang, for your just one question for
Yes.
you. Yeah, that's the EP is good as a scaffold as well as ILM is also good for scaffold. But epiretinal membrane, if in case of macular hole, is best not stuffed inside the hole. So how exactly make sure that there is not much of ERM tissue and plain EP tissues there?
Yes, that's
during the
right.
scuff?
That's right. In many cases, the tangential, first is the ERM causes the tangential traction. Then there's the formation of a laminar hole. After laminar hole formation, it stimulates the middle retina and the Mueller cell proliferate, and the EP tissue comes out. So always the conventional EP and the conventional epiretinal membrane and the EP. So we have to be careful to remove the conventional EP as much as possible. Thank you very much.
If you leave the epiretinal membrane, then wouldn't this epiretinal membrane reproliferate and cause an traction again? So you are leaving a lot of fibroblast and tissue there which can reproliferate.
Fibrovascular?
You are leaving a fibroblast and a membrane which contains a lot of fibroblast which can reproliferate. So isn't it better to remove this membrane and remove in total rather than using this? You use ILM2 as an agent where you can give an macular flap kind of a thing.
I'm sorry, because of the echo, I cannot comprehend your question. But my point is that we use the EP, we remove other tissue as much as possible. But sometimes it still is adherent to the underlying ERM or IM. In such cases, our studies show that with the EP, somehow it has some property that inhibits some severe proliferation, clear proliferation. Thank you.
But one of the arguments for peeling the ILM is that you're removing the scaffold for preventing ERMs from reforming.
Yes,
so
that's
if you
one.
leave the ILM, are you expecting now higher recurrence rates of ERM in your post-op patients?
Yes, that's right. In laminar macular hole, if we remove the ERM laminar hole, I'll always double stain with the ICG or BBG to see if there's a homogeneous pattern. Then I know there's ERM left, so I just leave it alone. But for macular hole, then I'll try to remove the ERM also. Yes.
One short
Yeah.
question. If you stuff the EP with IRM, so how about the ICG toxicity or something to the RP?
So I always try to remove all the stain the tissue, like the second video. Use the cutter, not cutter mode, but the shaving mode, so it will not pull the EP together. Thank you.
Great. Thank you very much. In the interest of time, let's move on to the next talk, which is failed macular hole surgery by Dr. Gupta.
First of all, I'd like to thank APAO and good morning, everybody. I'll be talking about failed macular hole, what to do. Giant macular hole is defined as base macular hole diameter more than 1000 microns with MLD of more than 800 microns. These holes have high rate of failure. Failure rate in macular hole of 650 to 1416 micrometer is somewhere between 19 to 24% in Manchester large macular hole study. Various strategies has been described to deal with failed macular hole, which involves inverted macular hole by Michael Visca, autologous ILM transplant, lens capsule transplant, neurosurgical retinal graft, amniotic membrane by Rizzo, retinotomy, and hydrodissection. I'll be talking about autologous ILM transplant, which I do, and I combine this with hydrodissection to deal with very large macular holes. So these are the management strategies for failed macular holes. And if you have an extra large macular hole, inverted flap, ILM autologous transplant with hydrodissection is my preferred choice. I don't prefer this retinal transplantation because I believe vision does not improve in these kind of patients once we do an autologous retinal transplantation. This is my first patient, relatively small hole. I did and went ahead and did an inverted flap in this technique. But you can see after 2 weeks of surgery, the macular hole is still open. The gas was still there, so I thought I'll ask the patient to lie down in prone position. But over a period of 4 weeks, you can see the macular hole is enlarged. I don't know, you can see the ILM flap here, you can see this small flap here. So according to me, I did everything right, but this hole failed. I took this patient for surgery and went ahead, restained this membrane, and with the help of a diamond dusted, I tried to find the edge of the flap which I have peeled earlier. So you can see I can find out the edge of the flap here. The flap is there, and actually what has happened here is the flap which I had made initially has stuck and caused a traction onto the retina. So since I get an ILM flap from my old flap, so I don't plan for an autologous ILM transplant, I go here, peel this, and it's important to bring this peel right till the edge of the macula. At this stage, many times I'm worried that I lose this ILM flap. So what I do, I put an PFCL so that I don't lose this ILM flap. Because if I lose this ILM attachment, then it becomes very difficult to put this ILM flap over the macular hole. Again, the ILM is brought right into the center, and a flap is made and put it over the ILM, over the large macular hole. Once this is done, go ahead and do a fluid air exchange, and you can see this 2 weeks post-operative results. The hole is closed, and this patient improved by 2 line to 636. Saying it's very easy that you say you put an ILM flap into a macular hole, but it's extremely difficult, and these problems are highlighted in this video.
Improved over the past years with the refinements in vitreoretinal surgeries. Closure of typical macular holes can be seen in over 90% of cases. However, non-closure can still be seen in some rarest of the rare cases. A variety of techniques have been described for managing failed macular holes like autologous retinal transplantation or amniotic membrane transplantation, but we still prefer using ILM grafts. It is easier said than done because resurgeries hold challenges at every step, so let's discuss about them. Challenge number 1, the wandering flap. In resurgeries, when we lift the ileum flap from a distant site, due to currents from continuous infusion, the transportation of flap becomes difficult. The fluidic turbulence leads to running amok of the flap. To avoid this, turn off the infusion, wait for the flap to stabilize, and then repose it. Challenge number 2, transporting the flap inside the PFCL bubble. While working under PFCL, if we lift the flap away from the retina, it sticks to the instrument. Once it gets stuck to the instrument, it becomes impossible to reposit it back. Challenge number 3, flap sticking to diamond duster. On attempting to separate the flap from the diamond duster, it sticks to the forceps, again impossible to free it. Challenge number 4, trying to introduce the flap inside the PFCL bubble. PFCL is immiscible with irrigating fluid and has got high internal surface tension. Thus, it gets difficult to introduce the flap from outside into the PFCL bubble. So what are the ideal ways to deal with these nuances or challenges? Begin with the basics. Stain good. Create a hinged flap with a blunted diamond duster, and after that pour ample amount of PFCL to cover it. This prevents the flap running amok and provides the needed counter traction. Roll the ileum flap under the PFCL to reach the hole without lifting the instrument. Take the help of chandelier illumination, do a PFCL exchange. At the same time, inject BBG stained viscoelastic substance over the flap. This prevents dislodgement of the flap. So with these techniques, we can face challenges in the resurgeries and finally seal the deal.
Now, with very large macular holes and failed macular hole, what I am doing is an hydrodissection technique of detaching the posterior pole of the macula. So in this video, after you can see it's a huge macular hole with a base diameter of somewhere around 1800 microns, and we stain this. PFCL is put and an hinged flap is created nasally. Once this hinged flap, I use a diamond duster to bring it right into the center over the macular hole and put this flap into the macular hole as an ileum transplant. And once this is done, I go ahead and detach the posterior pole. It's important that you detach the margins of the macula, and you can see the fluid coming here. The idea basically is to make the posterior pole more elastic, so once the retina settles down after detachment, it closes. And you can see the post-operative result. The hole is nearly closed and this patient improved to 624. This is another patient of very large macular hole, more than 1,000 microns of base diameter, and a square-shaped ab. The chances of failure are pretty high. So we went ahead and did this macular detachment with ILM flap, and you can see this patient attained his vision of 612 with a good closure of macular hole. And with this technique, we have done 9 cases, and in almost all our cases, the vision has improved. Only one case, there was in type 2 closure, and the vision, but in that case also, the vision improved to 636. So up to 39% of chronic macular holes and failed macular holes have been reported to have adhesions between the retina and the RP, contributing to difficulty with hole closure. This gives square edge appearance on OCT in contrast to the puckered edge seen in the acute macular hole. Advancement of macular tissue by increasing the elasticity of retina by ILM peeling, ILM scaffold over the macula because of the flap, and then doing a macular detachment and what we call as an hydrodissection of the macula results in improvement in our all our cases. The important thing here is if you go for a retinal transplant, then in most of the cases, although you can achieve an OCT closure of the macular hole, but the vision does not improve. With this technique, I am able to get at least 2 to 3 lines improvement in all my cases, and there is no metamorphosia post-operatively. The only drawback is I have done only 9 cases, but need more giant macular holes and failed macular holes to prove the efficacy of the technique. Thank you very much for your kind attention.
Nice presentation, Dr. Ravnindra. I mean, the free ILM flap technique under PFCL is a fairly good technique to cover a large macular holes as well. I mean, do you really think this is necessary to combine hydrodissection along with free ILM flap?
Initially, I had it because it's a pretty large macular hole, and many a times you find adhesion. One of the traumatic macular hole, what I was doing somewhere around 2000 microns, and I found there was an attachment between the macula and the disc. So until unless you have some kind of tissue which can advance and close the retina, you will not achieve a closure in very large macular holes. So combining both the technique, I am able to get good results with good visual improvement.
Dr. Pralay?
So I want to ask the site of injection of BSS. That created some nerve fiber layer defect, very thin portion.
Initially, I had a concern about this. Creating a detachment, I did an OCT where I created a macular detachment, and post-operatively I couldn't find any defect there. It heals because it's in 40 gauge opening, it heals by itself. So, and patient also didn't complain of any field effects what I did afterwards. So initially I had a concern about this. To get rid, to clear my doubts, I did these 2 things, OCT, through the area where I have created a detachment, and fields I didn't had any problems post-operatively.
Dr. Subhendu, please.
Yes, I have a small suggestion. You are just covering the macular hole with the ILM flap, followed by you are dissecting doing the hydrodissection for the macular hole. Okay, but if you are doing it the reverse, like if you are dissecting the macular hole first and just make it smaller in size, then put the PFCL and do the ILM graft over the covering the macular hole, because after doing the flap covering the macular hole, you are dissecting this macular hole area. That means your flap can anyway go out during the aspect.
Yeah, so in that case, what I have done, I have put viscoelastic, preferably Helon GV. So this was a concern because if you put an ILM flap in a fluid-filled eye, then it tends to get dislodged, what I showed in my video. So what I did was I put viscoelastic over it and then proceeded it for macular hydrodissection. But yes, we can do otherwise. Thank you for the suggestion.
Now,
Okay, thank you very much.
I request Dr. Martin Bellin to speak about macular buckles. I think, yeah.
So thank you very much for the opportunity to present today. I have no relevant financial disclosures. We're currently seeing an epidemic rise of high myopia globally, but as you can see from these epidemiological studies, that rise is particularly accelerated here in the Asia-Pacific region. So it's quite timely here at APAO to be talking about some of the complications of pathological myopia. And for us as retinal surgeons, we're not just going to be faced with more retinal detachments, we're going to be faced with more of the issues of myopic traction maculopathy, which is the content of my talk today. So myopic traction maculopathy, as we all know, is a relentless and progressive condition that starts with VMT or VMA. It then progresses into foveoschisis, eventual foveal detachment, foveoschisis, and then myopic macular hole formation, with the end result of macular hole retinal detachment. And this is due to a combination of both tangential traction as well as anteroposterior traction. And Barbara Parolini very nicely classified this in her publication a few years ago, where on the x-axis you've got tangential traction, on the y-axis you've got AP traction, and this allows you then to not just classify the type of traction that you have in your MTM, but it also determines whether you need to do a vitrectomy with macular buckle or just macular buckle on its own. And macular buckles have been around for quite some time. There is a poor uptake in the technique, I think, and particularly where I'm from in Hong Kong, there's now a little resistance, I think, generally towards even the fellows wanting to do buckles. But I persist with this because I think it is a technique that works very well for patients with MTM. And macular buckles are by no means new. They've been around since the late 50s. In Hong Kong, the only ones we have available are the L-shaped Parolini macular buckle and the AJL macular buckle. And even with the AJL, it wasn't until about 2 years ago that we had the import license approved, and we managed to convince a distributor to actually start importing these buckles. So here is a typical case of an AJL buckle. It's a very standard approach that I use. I put a chandelier light into the end of the buckle so that I can then, once the buckle is in place, transilluminate where the end of the buckle is. And as you'll see shortly, we can move the buckle around so that the transillumination is right over the area of the myopic macular hole. And once we've positioned it, we then just simply suture it in place. It's actually, if you're a good buckle surgeon, this is a very simple technique, and as you'll see shortly from my results, highly effective. One of the questions that I had quite early on when I was adopting this technique was really how much functional improvement do we get once we've implanted a macular buckle. And we seem to get very good anatomical results, and visual acuity doesn't seem to be a good endpoint measurement for knowing how well the macula is improving its function. So I decided to do multifocal ERGs on the patients at baseline, and then compare those to 1 month, 3 months, and 6 months post-operative after the macular buckle had been performed. And we also had a series of cases where 4 of them that would just happen to be the next 4 consecutive cases that I did macular buckles on were compared to a control group who were age-matched, also high myopes, but with no macular pathology as a means to control. So at this time, and this was data collected more than 2 years ago, we were using the Parolini macular buckle. And for those of you who may not be familiar with this technique, this is actually a macular buckle that we make in the OR. So we take a 5mm sponge, we put a hole through the middle of the sponge, and we push into that a titanium plate. We then slice the long arm of the buckle, as we call it, into a slightly slimmer shape so that it can fit around the eye. And then using the titanium plate, you can bend the buckle into an L shape, and hence its name. All of the patients had this L-shaped macular buckle together with a vitrectomy plus minus further ILM peeling and gas. And for the multifocal ERG, pretty standard 61 hexagon ERG from the Virus system. The results were that all our patients had previous failed macular hole retinal detachment surgery, so these were eyes operated on at least the second, if not the third time round. They all had long axial lengths and obviously high degrees of myopia. But even really large myopic macular holes, as the one that you see here, could be successfully closed using this macular buckle technique. We found that with foveoscisis foveal detachment, it does reduce over time, but during the 6-month follow-up period, there was one case of foveoscisis that didn't fully go back to its correct anatomical position. Here's a slightly different case, foveoscisis foveal detachment following the macular buckle, and you can see 6 months post-operatively, it's resolved very nicely. So on to the multifocal ERG results, and what we found was that when we looked at the first order kernel responses of the MF-ERG, this, just as a reminder, is an outer retinal generated potential. So this is coming from photoreceptors and bipolar cells. We see a statistically significant difference, obviously, in rings 1, 2, and 3, because this is where the myopic macular holes and fluid from the macular hole retinal detachment lies. And thus there is a big difference in the amplitude of responses in those areas, both in the P1 and, as you can see here, in the N1 responses in rings 1 to 3 as well. One quite interesting finding, I think, is that when you look at the second order kernel responses, which is an inner retinal potential from the ganglion cells, you see a much more widespread disruption of macular function. So whereas the outer retinal dysfunction seems to be localized to where the pathology is, the inner retina seems to have a more widespread disruption of macular function. And when we then performed sequentially the multifocal ERGs postoperatively at 1 month, 3 months, and 6 months postoperatively, we found that on the first order kernel responses that the statistically significant recovery of amplitudes were seen initially in the outer rings, so towards ring 3 and 4, then later in rings 2 and 3, and then finally at the fovea at ring 1. So the recovery of function seems to, even though the whole of the macula goes flat immediately postoperatively, the recovery of retinal function seems to go from the outside of the macula inwards. And there are various theories that we can debate as to why that would happen. So in conclusion, the study, which is really just a small case series, showed here that after successful macular hole retinal detachment or foveoscisis foveal detachment surgery, functional improvement starts from the periphery of the macula and works inwards. The inner retina has more widespread dysfunction, and it does not recover as well postoperatively. And when we looked at all sorts of regression analysis to see whether any of these parameters are associated with visual acuity improvement, we found only the paracentral inner macular dysfunction on the multifocal ERG was correlated. With that, I thank you all for your time and attention, and I welcome you all to Hong Kong next year for APAO 2026. Thank you.
Thank you, Dr. Martin. Yeah, there's one question that we'd like to answer is that how do you go about the decision making regarding offering a macular buckle versus vitrectomy ILM peeling in case of MTM? Is it based on axial length or some configuration of the OCT that you design?
Yeah, I've now actually, and I've spoken to Barbara quite extensively about her publication. This classification I've actually printed, and I now have it in my consultation office on the wall. And I actually use this as a means to decide which type of surgery to do. If you look at the bottom left of this classification, you'll see an example where you've mainly got traction, which is in the anterior posterior. And strictly speaking, those could be fixed without even doing a vitrectomy. You could just fix those with a macular buckle because it's the elongation which is the main tractional component. Likewise, if you go to the other extreme, which is the top right, where you've got only tangential traction and you have myopic macular hole, those don't need a buckle. They could be fixed just with vitrectomy, ILM, peeling, and gas. And then obviously in between that, and the extreme example would be bottom right, you would be looking at a case of a macular hole detachment where both tangential and AP traction is the issue, so you would probably look at combining the two surgeries in those cases.
Yeah, I like your ERG result, but if the patient has a very severe glaucoma, and we wonder if this patient is for the vitrectomy or something, ILM peeling, but in that cases, I think the macular buckle is indicated because it is used without vitrectomy. In that case, we should remove the anterior chamber fluid and lower the pressure, and we can select the location of the buckle. Because with vitrectomy, we can lower the pressure to see where is the buckle, but this macular buckle merit is used without the vitrectomy, I think.
It's a really excellent point, and I'd like to add to that I think the current AJL design, the buckle is too high, it's got too high a dome on it. So we actually get too much pushing upwards. And what I find with the Paralini buckle is that it's actually a much flatter buckle. And we see on the OCT that the retina's kind of got a flatter profile on the macula after that buckle, whereas with an AJL, it almost goes convex, it goes the other way. And I think that's kind of overcooking it. I don't think we need quite that much pressure from the buckle. I think we just need to relieve the traction a little bit, and then usually we get anatomical success. So yeah, absolutely.
Some surgeons complain that it's difficult to fix or locate the buckle, but if we remove the anterior chamber or lower the pressure with vitrectomy, so the buckle is spontaneously under the staphyloma, I think, yeah.
Absolutely.
My institution is Dr. Ando's institution, so
yes,
the,
absolutely, yeah.
a lot of
the Ando
experience.
Plum was obviously a very, very famous buckle, yes. But that's a great technique. So lowering the pressure and allows you to mobilize the buckle better. Yeah, thank you for that.
Thank you very much. So next is macular surgery for subretinal hemorrhage from Takeshi Iwase from Japan. So thank you very much. Could you start lecture?
Something strange. So the PC doesn't work. Please, someone help me. Okay. Okay. Thank you for having me in this conference. So I'm talking about macular surgery for subretinal hemorrhage. So submacular hemorrhage, SMH, is a rare complication of choroidal or retinal vascular abnormalities associated with AMD, PCV, and retinal macular aneurysm. PCV is most commonly linked to large SMH. SMH leads to photoreceptor damage due to iron toxicity. Irreversible retinal injury can occur within 24 hours. Only 11% of cases achieve BCVA better than 20/100 after 2 years in old reports. So treatment options for SMH. So anti-VEGF monotherapy, pneumatic displacement with anti-VEGF, intravitreal TPA, tissue plasminogen activator, plus anti-VEGF plus PD, and paraspiral vitrectomy, PPV plus TPA injection plus pneumatic displacement. So subretinal injection of TPA without retinotomy minimizes retinal trauma. It reduces the risk of complications such as PVR and retinal detachment. This less invasive approach may lead to faster recovery and better visual outcomes. So I will present several cases of SMH. So first case is SMH caused by trauma in 53-year-old male. While playing baseball, he was struck in the left eye by a battled ball. He noticed a sudden decrease in vision. So the vision decreased to 21,000 in left eye. So we can see the SMH in the macular region. So I did PPV plus subretinal TPA injection plus pneumatic displacement. The video shows so subretinal injection using 38 gauge needle. So you can observe progressive detachment. At the end, so air is injected around half of the vitreous cavity. So after surgery, so hemorrhage is depressed and vision improved to 20/20. So next case is a rupture of PCV in 67-year-old male. The patient noticed decreased vision in the right eye about 1 week ago. The vision decreased to hand motion in the right eye. So photograph shows extensive hemorrhage. And so OCT clearly demonstrates a significant height of SMH. So I did PPV plus subretinal injection of TPA plus pneumatic displacement. So video shows massive subretinal hemorrhage. So IN was peeled to facilitate needle penetration. So TPA was injected to make wide retinal detachment. So here. And then, so fluid air exchange to displace the detachment posteriorly, like this. After surgery, successfully, the SMH was displaced inferiorly, and the vision improved to 20/60. So next case is a rupture of retinal macular aneurysm in 81-year-old female. The patient noticed a sudden decrease in vision in the right eye since yesterday and was subsequently referred to our hospital. The SMH is relatively fresh, and so OCT shows outer retinal layer relatively preserved. So I did PPV plus subretinal TPA injection plus pneumatic displacement. Core vitrectomy was performed, so using magnified lens, so IM was peeled, and sub-IM hemorrhage was aspirated with cutter, and then TPA was injected to make retinal detachment. So you can see retinal detachment is this size. At the end, so fluid air was injected around half of the vitreous cavity. So day one, SMH was successfully displaced inferiorly, and macular condition looks good, and the vision improved to 20/25. So next case is also rupture of retinal macular aneurysm in 91-year-old female. The patient noticed a sudden decrease in vision in the left eye 2 days ago and was subsequently referred to our hospital. The vision decreased to 2400. So fundus photo shows SMH as well as sub-IM hemorrhage. So this is a kind of tricky case. So SMH is not so severe, not significant, but so we can see sub-IM hemorrhage. In such case, the possible of existing of macular hole couldn't be ruled out. So I did different surgery, PPV plus IM peeling. Something strange. So combined cataract surgery was performed, and phacoemulsification was performed to remove lens, and then IOL was implanted. So usually I used 25 gauge constellation system. So capsulectomy was performed. So in such case, just so ILM was peeled, not removed. So carefully, so sub ILM hemorrhage was aspirated to confirm whether the macular fold was formed or not. After confirmation of macular hole formation, so peeled ILM was repositioning. And then so fluid air exchange, kind of ILM converted inverted flap. After surgery, so SMH had resolved and successfully macular fold was closed. OCT image showed inverted ILM flap, and the vision improved to 20/50. The next case is a rupture of AMD in 68-year-old female. 2 days ago, the patient experienced a sudden decrease in vision in the left eye and was referred to us with a diagnosis of retinal detachment. So this patient came to our hospital 1 year ago. At that time, only so drusen was observed and vision was 20/20, but at this time, the vision decreased to right perception. Fundus photo shows total hemorrhagic retinal detachment, and ERG amplitude was in the left eye was flat. I did PPV plus TPA subretinal injection plus retinotomy plus removal of subretinal hemorrhage. Core vitrectomy was performed, and so SMH was coagulated. And so TPA was injected at multiple sites to dissolve the coagulated hemorrhage. So after dissolving the hemorrhage, so I cut the peripheral retina to remove the SMH completely. So perfluorocarbon liquid was injected to attach the retina, and then so photocoagulation was applied to the retinotomy site, and finally perfluorocarbon silicone oil exchange was performed. After surgery, so total hemorrhagic retinal detachment was reattached, and the vision improved to 2400. This is the last case of rupture of PCV in 76-year-old male. The patient had been experiencing blurred vision for a while, but had left it untreated. After visiting a local clinic, he was referred to our hospital.
Dr. Vivasi, I think can we take a question now?
Oh, okay. Sorry.
Excellent presentations, videos and all. But just the very first case that you showed, where subretinal hemorrhage, there's no subhyaloid hemorrhage. It is limited to the within the arcades. That particular case maybe could have done with intravitreal TPA and gas rather than vitrectomy, subretinal TPA and gas. What is your take on that?
So, good point. So, in such case, one of the options is, so as you mentioned, so TPA injection plus pneumatic displacement is maybe so good option. But I chose subretinal injection. But I don't know so which is better for final vision. But one of the options is, as you mentioned, TPA intravitreal injection plus pneumatic displacement.
One alternative technique is to use a non-vitrectomized subretinal injection. So you just use a 41 gauge cannula and you actually mix together your TPA, anti-VEGF and a little bit of air, and you just do a single injection without the need to do the vitrectomy. So we've adopted this technique for the cases of small submacular hemorrhages. Yes, question from the floor.
Like for your question, like without doing non-vitrectomized eye, if you are giving the subretinal TPA injection and the cocktail of anti-VEGF and the air, so what will happen, like after injecting all these three cocktail injection, you have to displace the lysed blood from the fovea. Otherwise vision won't improve. That will not be possible after if you are not doing the vitrectomy completely. So you have to do the vitrectomy and do the fluid exchange at the last and finally and inject some SF6 or C3 gas so
No.
that you can completely disperse the blood from the macular area.
No, I disagree. The purpose of the subretinal air is for the blood displacement. The beauty of putting the air subretinal as well is that
Yes.
the patient doesn't need to posture.
Yes, if you are giving the subretinal injection and ask the patient to like
Just
sit down.
Just sit up.
the sit up position for 12 hours at least, so that by the lysed blood due to the gravity, the RBC will go down and the air will come up,
Yeah.
and the blood will go down and it will be the fovea will be devoid of blood. And
Yeah.
if you are doing the gas injection and after 12 hours, if you are positioning it in a prone position, so the rest of the blood will go to the peripheral position, so the macula will be absolutely lack of blood. So your vision and the field of vision both will improve. And your question, if it is less than 4 disc diameter in size, submacular hemorrhage, definitely intravitreal injections or anti-VEGF will work, especially the nodosulimab kind of strong anti-VEGFs. And for you, like when there is total retinal detachment along with subretinal hemorrhage, if it is extending towards up to the ora serrata, you have to do the retinectomy as close to the ora serrata possible. And if the duration of the hemorrhage is more than 2 weeks, you have to do the RP choroid full thickness graft transplantation, because in this situation, the RP condition is absolutely very bad. You have to remove the CNVN part also.
Thank you.
Then replace it by the RP choroid graft. Then only you can get a very good vision. Thank you.
Thank you, Dr. Subendra. Now I have two excellent talks remaining. It's in robotics by Kohei Sonada.
Thank you, Chair. I'm very honored to be here. And my topic today is the robotics for vitreoretinal surgery. And this is my disclosure. And there are several robots for vitreoretinal surgery. And one pioneer from Japan, Dr. Sakai, created the master slave minute miniature robot for vitrectomy. And actually, 2014. And in Europe, one of that famous company, Precise Corporation, has demonstrated robotic safety assistant in vitrectomy. And it is very cool and no remote center of motion, resembling of surgeon's movement, plus removing tremor. And I have idea. So the endoscope assisted vitrectomy is a little bit expanding in Japan. It's effective in case with corneal opacity, small pupil, and hazy anterior inflammation. And at present, surgeons have to hold the endoscope by themselves, which occupied one hand. So I hit the idea. We just proposed a novel robotic endoscope holder to allow surgeons dual hand manipulations. And this is the prototype robot in the stimulated eye. And the surgeon can look at the fundus through both microscope and endoscope. And you can see that the robot can hold the microscope and moves very smoothly. And surgeon can do the surgery by bare hands. And this is the process of development. In 2017, Emmett Japan Agency for Medical Research and Development, I get the grant. And 2019, we get the basic patent and 6 related patent. And we pre-consulted PMDA, Pharmaceutical and Medical Devices Agency in Japan, and got medical device class 1 certification. And 2023, PMDA approved as medical device class 1, and then it was released to market in the spring of 2023. And this was a system robot for vitreoretinal surgery named Okurimo. And Okurimo can hold and maneuvering the endoscope illumination as surgeons another hand. And all procedures can be controlled by foot controller at the surgeon's well. And rotation, zoom in, zoom out, maneuvering, everything. And strongly recommended to a stopper to prevent too much insertion. In case of emergency, just kick the side wall and immediately evacuate it from the eye. And we can simultaneously use Okurimo endoscope and wide viewing system. Okurimo endoscope is good at observing the peripheral fundus. Wide viewing system is good at observing posterior pole. And so far, we experienced total 9 cases of Okurimo endoscope. And you can see that 8 cases for local anesthesia and 1 case is general. And for the surgical indications, 4 cases for silicone oil removal and 3 cases for checking peripheral retina, and 1 case is armed valve implantation for via pulse planner. And I pick up 3 cases in this presentation. The first case is a 46-year-old male, acute retinal necrosis, PPV, and 6 months later, I removed the silicone oil. And you can see that clear trochal area and cutter both temporal and nasal side. And I found a small retinal break in the lower parts. So I did fluid gas exchange and do the laser without indentations through endoscope. And the second case is 25-year-old male, sarcoidosis, PVR, and I did PPV, and 3 months later, I removed silicone oil. And you can see again that you can find that many tiny particles in the vitreous fluid, and I wash and wash, and then getting clearer in the temporal side and nasal side. And I found the pool of small minute particles in the temporal side, and I carefully removed by the endoscope without indentation. And the last case is 15-year-old female, JIA uveitis, a secondary glaucoma, and I did armed valve implantation. And you can again see, I put the illumination through the sclera, and we can clearly see the confirm the planned puncture site. And finally, we can confirm the vitreous body and was completely removed from the tube. And this technique was suggested by the Professor Shintaro Nakao, Juntendo University. And all patients have no complication. Without indentation, Okurimo endoscope is good at observing the peripheral fundus, including retinal break, residual silicon oil, and trocar tube position, etc. It might be exciting to develop new maneuver using Ocrimo in future. And this is our team, Ocrimo and collaborators. And this is my final slide. I'm going to chair the 130th annual meeting of Japanese Ophthalmological Society in the next spring. So please visit Fukuoka in Japan. Thank you for your attention.
So endoscope is with robot is a very nice machine. So can we use? I haven't used that. Always it's on a commercial only in Japan.
Yes, only in Japan. But it was some interference to the microscope and endoscope, but it was adapted. And there is a learning curve, but as you can adapt it, it will be a good tool to assist your vitrectomy, I believe.
Okay, so that the 20 vitrectomy is 25 or any?
It's a 25 gauge
25
needle.
gauge. Thank you.
Yeah. Can it be used in any which way to help our lives in subretinal injections? I mean, currently
I don't think so. Maybe the next speaker will present the subretinal injection, but it is the robotics for assistant robot, holding endoscope for illumination, some other things, and the surgery, we did the surgery smoothly. It's an assistant robot.
I think thank you very much, that was a great talk. I think if I'm not mistaken, the last speaker is unable to be here. So am I correct that the next will be a video presentation? I'm looking for confirmation. I believe Professor Lin hasn't been able to attend, so I think we're going to set up for a video, which is rather timely because it's on the theme of robotic surgery still. And it's a device that I actually crossed the border to have a look at myself. It's a company based up in Guangzhou, and they've made a very interesting subretinal injection robot, which I went there to try in their wet lab. It's a really nice piece of kit.
Today, I'm honored to represent our team and showcase our remote robot for assisted vitreoretinal surgery. There is no conflict of interest. JLC is the leading eye hospital in China, serving over 1.4 million outpatient visits annually, with more than 100,000 surgeries performed, including cataract, vitreoretinal, and reflex surgery. JLC is a leader in the field. JLC has been ranked first in ophthalmology by the best hospital in China for 40 years in a row. We now serve as the WHO Collaborating Center for Eye Care and Vision and host the headquarters of APAO, which is committed to exceptional patient care, education, cutting-edge research, and global collaboration. JLC remains at the forefront of ophthalmology in China. On the occasions of our 16th anniversary, we are excited to host the International Ophthalmic Hospital Presidents Summit. We welcome you to reunite in Guangzhou for this precious ophthalmic assembly and immerse yourself in the charm of South China. In terms of research, JLC houses China's only state-key laboratory of ophthalmology, focused on cutting-edge research in stem cells, neurobiology, artificial intelligence. We have been ranked #1 by the Science and Technology Evaluation Matrix for 10 years in a row. Our pioneering work has positioned us on the top list of the Nature Index for Eye Institute research output. JLC serves as a national educational base for PhD students and clinical residency in ophthalmology. Our graduate students and alumni have achieved national recognition, with many becoming professors at renowned international universities. Currently, the global burden of eye health is significant, with an estimated 1.4 billion people suffering from untreated vision loss by 2015. As depicted on the right, 90% of these patients reside in low and middle income countries, with the highest proportion in Asia and Sub-Saharan Africa. Among all the eye disease, retinal disease represents a major irreversible cause of blindness. More critically, the distribution of ophthalmic resources is uneven, with fewer than 40 ophthalmologists per million people in these countries, and it takes over 10 years to train a qualified retinal surgeon. Experienced surgeons are concentrated in tertiary hospitals, leaving many patients without timely treatment and leading to vision loss. The human eye, with its retinal thickness ranging from 150 to 300 mm, requires extremely dedicated and stable surgical operation due to the physiological tremor of the human hand, which is about 108 mm, comparable to diameter of human hair. Take subretinal injection, for example, is critical treatment for conditions like as submacular hemorrhage and inherited retinal disease, slow gene therapy. However, it is limited by the high operational difficulty. With technology advancement, robotic assistance may reduce the complexity of these surgeries. Thus, our team of doctors and engineers collaborated to develop high-precision ophthalmic surgery robot. The robot offers micrometer-level precision, reducing human movements down to 1/13. The video on the bottom left demonstrates its 10 mm position accuracy and 0.01 angular precision, which is among the top-tier accuracy internationally. Its remote center of motion (RCM) ensures that instrument will rotate around the surgical incision without pulling the eyeball, preventing iatrogenic damage. The robot also supports both local and remote control, filtering out tremors, slow, sophisticated occlusions. This is a table comparing the current mainstream ophthalmic surgical robot. Our ophthalmic surgical robot is based on master-slave manipulation, and in addition to its high positional accuracy, it has the following advantages. First is motion scaling range is 3 to 13 times. And secondly, its RCM is software implemented utilizing a hybrid halo-zero manipulation data, which can be flexibly adjusted, and surgical RCM has 5 degrees of freedom. Finally, our robots have strayed into clinical trial stage, and all of them have achieved 100% surgical success so far. This video compares the stability of manual versus robotic assisted operation it is evident that the robot provides significantly more stability than human hands. This last year, our robot used in clinical ophthalmic surgery. The video displayed the treatment of submacular hemorrhage in a 60-year-old woman by subretinal injection of RTPA. The instruments are very stable as the drugs were precisely delivered to the lesions of, to dissolve the blood clot and lead to a good recovery for the patient. We also developed a remote robotic visual-retinal surgical system using 3D ultra-high definition video technology. Surgeons receive a detailed binocular view. Concurrently, a remote robotic system enables precise instrument manipulation by handling a motion controller. The average delay of 5G network was only 25 milliseconds. In June 2023, our team successfully conducted the world's first real-time remote surgery on rabbit eyes over a distance of 600 kilometers across the Hainan Strait. All 30 surgeries were successful, garnering coverage from over 20 media outlets. Showcasing our work, this video the video displays a successful subretinal injection via the remote robotic system from Guangzhou province to Hainan province across the sea. The left part of the video is the surgical view, of surgeon. The right part illustrates the use of a smooth insertion of the 41G needle into the retina and the subsequent injection process, all complete without including hemorrhage or other complications. The OCT images offer a preoperative and postoperative comparison of rabbit's eye. 3 hours after surgery, the solution spread between the neural retina and the RPE layer is distinctly visible. Within a day, the retinal lesion begins to heal, and by the 7th day, full recovery is evident. The video shows that we successfully removed intraocular foreign body from pig eyes under remote control. The procedure was smooth and did not damage the retina, providing that the remote system can adapt to different surgical scenarios. The 5G network across multiple sites, yet no failures, and the system demonstrates nearly identical latencies across all 3 centers, ensuring reliable remote operations. In conclusion, our findings demonstrate that this system can safely and steadily perform remote intraocular microsurgery and is versatile in terms of instruments and geographic locations. Lastly, I would like to thank the members of our team and the collaborative partners. This presentation is helped organized by Andy Xu. Also thank all the kind peers for all their help. Thanks. Good morning, ladies and gentlemen. My name is
Okay, great. That was actually the last talk. Now, I'm sure Professor Lin doesn't mind. If there are questions relating to that subretinal injection robot, then I can try and answer them. I collaborate with Professor Lin, and as I mentioned earlier, I've tried the robot. So if there are questions, maybe
one
just
question to you,
yes.
Dr. Ma. How far are we from actually the robots being commercially available in the rest of the world? I mean,
Yeah, very good question. So this is one of the hindrances, even when we try to get it from mainland China into Hong Kong. The regulations and the certifications that are needed are different in China as compared to Hong Kong. And that's surprising because it's essentially the same country now. And it's one country, two systems, but there's different regulations still. And so we were really keen to adopt this robot and use it in non-vitrectomized subretinal injections, but it's still an ongoing process of getting all the papers sorted. Interestingly, this robot developed at Zhongshan Ophthalmic Center has been through a really large clinical trial in mainland China. So they've had a multi-center study now done with significantly more patients, and the results look very, very promising. So what I'm most impressed about with Professor Lin's project is that not only has he done robotics, but he's also done telesurgery. So he's remotely able to operate the robot using a 5G high-speed connectivity link. So I think it sort of brings in a new era of remote surgery, which we will likely see more of in the future. Yeah.
There's one question from the audience, please.
For the interesting talk on robotics. I was just wondering, in terms of logistics, how, if the surgeon, vitreoretinal surgeon is in a different country, how does the docking and the insertion of instruments, who does that on the site at the patient's?
Yes, so you'll need two teams. You'll need one team on site that puts the ports in. And also for the robot, they have now developed a technique where the robot can kind of steer itself, not just towards the patient, but also into the port. But as far as I'm aware, that software upgrade is still in research stage. And so you actually need the on-site team to actually put the robot arm inside the port as well. But once it's all set up, the on-site team is then hands-off, and it's the remote surgeons that then take over.
So is the on-site team the technician, or does that have to be an ophthalmic surgeon as well?
So the on-site team are there with the patient, and then the surgeon is remote. So yeah, the reason why they developed this is because China is such a vast country, and they have a lack of senior VR surgeons. So they're really keen to develop this because they're seeing it as an opportunity for training up lots of smaller hospitals to be able to set up the patients, but then have a senior and skilled and experienced surgeon to do the operations at one center. Yeah.
But the on-site team, can it be a technician, or does it have to be an ophthalmic?
Oh, gosh, that's a good question. A short answer is I don't know. Whether you actually need a surgeon, I'd imagine you'd need a surgeon because you need to put in ports. But whether you'd eventually be able to train up technicians to put in ports, yeah, that's maybe further down the line. My understanding of their setup at the moment is that they've got two surgical teams, one on-site and one remote. Yeah.
Sorry, one last question. Are the ports the same, similar, or very similar ports to what we use now?
Identical. They're the same ports.
Thank you.
And one more question?
I have two questions. So one is, I saw on the presentation the delay time is about 500 milliseconds. It's half a second. And is that comfortable for surgeons at the moment, or do we need like a faster network, like maybe 6G in the future for more smoother surgery? And the second one is, you mentioned non-vitrectomized surgery or injection. Do you have a publication that I can refer to?
So the first question is again quite difficult for me to answer because I was not one of the surgeons that tried the remote accessed surgery, the remote surgery, the telesurgery. I'm not sure quite what to call it. I only tried the machine on site in their wet lab. So my experience is limited. I haven't even tried it on a patient. The feedback from the research team at the Chongshan Ophthalmic Center was that the latency wasn't an issue, but they said that the limiting factor here is 5G connectivity. So once connectivity speeds are faster, we would imagine that latency would be reduced even further. So I guess, I guess that's answering the first question. The second one, yes, there are publications on non-vitrectomized subretinal injections. The first was a case series in the journal Retina, the primary author of which I'm embarrassed to say I've forgotten, but they were the first to report the technique. And then we've published from our department a couple of papers on management of submacular hemorrhages, comparing vitrectomized and non-vitrectomized techniques. And the primary author of that is my colleague Simon Sito, who will actually be talking on the next session. So he could also perhaps answer some of your questions on subretinal injections. But yeah, we're now switching to small macular hemorrhages, just doing non-vitrectomized subretinal injections. It's a nice technique.
Thank you so much. So Carl Zeiss had also come up with a robotic prototype a few years ago, the Bracious system. So that was used to remove epiretinal membranes. How is it akin to that or the system? And have you tried to remove epiretinal membranes as well?
Oh, so I haven't had experience with using that system. I know which one you mean. It was a robotic assisted epiretinal membrane, wasn't it, to try and remove tremor from your hand. I haven't personally tried it. I wonder if my chairs have tried that system. No.
I don't know what happened with it.
Stage of development. Very interesting question because there was a lot of excitement about this instrument, and then then it just disappeared.
Currently, I feel it's only the subretinal injections and the gene therapy. That is where I think the robotic assisted will be useful. I mean, ERM surgery, I think we've been able to do quite well, as you've shown as well. So I think, thank you all the delegates. With this, we close the session and we can chat up with at coffee. Thank you.
Thank you. Thank you. Shall we have a picture? Can all the speakers, if you're still here, come onto the stage, because we'll have a picture together to just commemorate the session.
Thank you very much.